I'm just a simple country doctor. Worked delivering babies for 25 years up in Louisville, Texas, Denton County. After 9/11, had a period of introspection where I wondered if I was doing what I was supposed to be doing with my life. My member of Congress said he wasn't going to run for re-election, so I did, and here we are.
Yeah,
So,
I have always been interested. Obviously, this is the first time we've met, and I want to talk about healthcare, but I want to actually ask about those early days in that first campaign against the Army family dynasty. And what was that like, throwing your name in the hat against, I'm sure, was a machine at the time, and then ultimately winning that Republican primary?
as they say, ignorance is bliss. I didn't know what I was getting into. I had to Google how do you run for Congress because I wasn't really sure. Turns out it's not that difficult. You get to the Secretary of State's website, you download a form, and all the questions are easy. So from that standpoint, I was on my way. Yeah, it's hard to do that. I was, of course, maintaining a full practice at the time. So it was, let's just say every day was pretty full.
Yeah. So I want to get into health policy, but I always like to take these opportunities to highlight the human side of government and the hard work it can be on one's soul to be in public service right now. What is it like serving in Congress now versus 5-10 years ago, or even when you first started almost 20 years ago?
Okay, this is going to sound counterintuitive. I feel that my service in the United States House of Representatives is actually more impactful now than it was 5 years ago. Of course, I've got a little bit of additional seniority, and committee work is I'm a little bit higher on the dais, but and again, this is going to sound counterintuitive, but these last 3 years of this administration, for all the bumps, it has been the most productive. I served 6 years with George W. Bush, 8 years with President Obama, but this last 3 years has been the most productive. Healthcare, to be sure, and of course, other aspects of what we're required to think about as legislators.
What do you give us some insight on what that repeal and replace process, and ultimately in the Senate becomes skinny bill, but what that process looked like? For people who don't know, the Energy and Commerce Committee in the House is really a powerful committee. It's the place where this legislation has come through, and you serve as the ranking member, former chairman of the Subcommittee on Health. Walk us through what that policy process was like during the repeal and replace piece.
Oh, look at the time. It's been fun being with you this morning. I try not to revisit that. Look, it was, you can always look back and say, well, there's places where you could have done things a little bit differently and perhaps a little more efficiently, and maybe the outcome would have been different. Nevertheless, from the committee perspective, our committee, the Committee on Energy and Commerce, was tasked right out of the box of the start of a new administration with fixing some of the problems that everyone was well aware that were there as a result of the Affordable Care Act. And the principal problem to be fixed was that of affordability. Ironically, the Affordable Care Act made things less affordable. My district is a perfect example of that. I'll have people come in all the time. Yes, I have people come in and say they're concerned about coverage for pre-existing conditions. Yes, I understand. That's important. The President said nothing's going to damage that. But far more often, someone comes in and says, we don't get a subsidy for our health insurance. We're in the individual market, and every time they raise the premium for the benchmark silver plan, people who have a subsidy get protected, but we're not. And as a consequence, our premiums are going up so high, we simply can't sustain that. And at the same time, deductibles are also increasing to the point where if something happens that requires us to go to the emergency room, a $4,800 bill will be borne entirely by our cash flow as a family, and we simply can't afford it. Now, people didn't put it quite precisely in those words. I inserted the silver loading part, but that was the issue at the beginning of 2017. How do you bring this, dial this back and bring it back into a realm that reflects reality? And that's what the bill that we marked up for 29 hours in the Energy and Commerce Committee. I'm also on the Rules Committee, so I got to spend another 20 hours with it a few weeks later on the Rules side. Hence my reticence to talk about this, because I invested so much of my life in it. The bill that we worked through committee and got produced for the floor of the House was a bill that, yes, it released people from the individual mandate. It removed the employer mandate. It reduced some. It did not eliminate all of the taxes, but it reduced some of the taxes, some of the ones that are considered most egregious. And in fact, in a bipartisan fashion, the Congress just eliminated the Cadillac tax, the device tax, the health insurance tax. So these were tackled in the bill that we brought forward to the floor. It did provide a soft landing for states where adults had been into expanded Medicaid. There was a governor of a medium-sized Midwestern state. I won't identify the individual. State begins and ends with O. And this governor was very helpful as we started out and said, look, one of the things I found, we expanded Medicaid in the state, and one of the things we found that if you place a re-enrollment requirement on your Medicaid program, there will be a significant amount of attrition. Now, what no one could have known at that point was how the economy was going to respond over these next 3 years. And the fact that Medicaid rolls have reduced is not so much that people have been pushed out of a Medicaid program, but they found employment. People are coming off the sidelines and back into the workforce. We have an economy that's producing more jobs than workers, and as a consequence, some of the things you referenced, income inequality, wages at the lower end of the income scale have increased faster than at any time in recent history. So would that have worked perhaps even better than the governor informed us? I don't know. The stage was set, though, that was certainly a possibility. Beyond that, the bill changed the subsidy from a subsidy to a tax credit along the lines of what Senator McCain had talked about in 2008 when he ran for president. There were people on, in full disclosure, there were people on my side of the dais who did not like that. They don't like subsidies, but they don't like tax credits either unless you've earned the money yourself, in which case, if you get the money back, that's a good thing. But if it's a pre-fundable tax credit, that makes it a little more difficult and a little less palatable. But nevertheless, that's what was incorporated in the bill that eventually left our committee after many, many hours, went up to the Rules Committee, changed a little bit in the Rules Committee on the first go-round. The concept of risk pools and reinsurance. Health Affairs had just published that article on the detailing the experiences with the state of Maine and the risk pool that they had introduced several years prior, and how that had brought the premiums down. So this was thought to be good policy, and it was added at the Rules Committee. The bill went to the floor of the House. Again, there were people on the right side of the equation who didn't like the tax credit and didn't like the fact that more of the Affordable Care Act was not taken away. I would argue that the journey of 1,000 miles starts with first steps, and this was a good first start. Let's get to work on this, but for whatever reason, the Speaker then said, we're not going to bring this to the floor. The bill got changed more, if you will, pulled a little more to the right, did eventually pass on the floor by 1 or 2 votes, and failed in the Senate by a single vote. With all of that said, the latter part of 2017, including the individual mandate in the tax policy that passed, in my opinion, the individual mandate was the part of the Affordable Care Act that really, my opinion, not speaking for the committee here and certainly not speaking for the Republican conference, but this is what made the Affordable Care Act so unpalatable, was this coercion, this push that the government places on people. Nowhere else in our society had that existed before, and it certainly was a new concept. Justice Roberts, when he evaluated this in 2012 at the Supreme Court, agreed with that philosophically, but then fell back on the fact that, hey, you're the Congress, you can tax, you can do whatever you want with the tax, so it's a tax. So it was appropriate to put it into the tax bill, and that's where the zeroing out of the individual mandate, that's where it occurred. That then has set the stage. You want me to go on?
You're doing great.
That then set the stage for things that have come forward out of the administration. And look, I was, the morning that President Trump stood up and said, I want to be known as the healthcare president, a lot of us went, oh, what do you, wait a minute, not so fast. But you look at the policies that have come out of the White House since the time the individual mandate was zeroed out. Really, my opinion, my thesis is that this establishes a roadmap for us to follow on the legislative side if we really wanted to affect meaningful reform. Maybe not do it all in one piece, maybe not do it all as one big bill, but there are certainly things that you can look at, and one of the things the administration did early in that process was change the rules surrounding what's called limited duration health insurance. And limited duration plans had always existed. These were sort of transitional plans to get someone from between jobs, someone out of school, out of graduate school, over the age of 26 that now needs an interim plan to get them into wherever they may end up as far as their employment, and in an employer-sponsored plan. But limited duration plans have been around for a long time. In the Affordable Care Act, as a result of more of a rule rather than legislation, the limited duration plans were limited to 3 months. So that certainly curtailed their utility. The Trump administration said, rather than 3 months, let's make it 364 days, and we'll make them renewable a couple of times. And this is one of the things, again, my thesis, that has brought probably 500,000 more people into the ranks of the insured than were before this policy began. Just backing up a little bit more, one of the things we've heard of people who want to do away with all private health insurance, which would include employer-sponsored insurance, insurance in the large group market, which arguably, and look, I'll stipulate here, my apologies to anyone who's in the insurance business, but no one likes their insurance company, right? I mean, I'm a doctor. I've fought with insurance companies my entire professional career, but no one likes their insurance company unless you try to take it away from them, in which case they say, hey, I was using that, you can't have it. So the fact that the economy has improved, and this got no traction in any headlines because the CBO report came out the same day the Mueller report was released. But under the first 2 years and several months of the Trump administration, those covered by large group market plans, ERISA plans, employer-sponsored insurance plans, had increased by, I think the number was 3.6 million people. Well, that's a significant coverage increase. Why did that not get any headlines? It was just sort of absorbed into the news of the day. That, coupled with the number of people that had picked up coverage under the limited duration plans, again, you're beginning to talk about some significant numbers of people getting coverage. You never see those headlines. Now, the Trump administration, I think in a wise move, said, these large group market plans, these ERISA-governed plans, the multi-state plans that, say, a large telecommunications company might have, where they have employees in literally all 50 states, and so they need health insurance that is not, they have argued that we don't want it to be state by state, we want the ability to offer multi-state plans. The compromise that was reached in 1996 between Bill Clinton and Newt Gingrich was that these plans would be governed under a set of rules in the ERISA under the Department of Labor, and as a consequence, the There's no exclusion for pre-existing conditions. You get through your probation period in employment, and the benefits then start, and there is no exclusion or underwriting for pre-existing conditions. The Trump administration looked at that and said, how could that be expanded? And one of the ways would be the development of what are called association health plans. I would have loved an association health plan when I was ran my practice. If I could have partnered, say, with doctors in county medical societies around the country or doctors in state medical associations around the country and bought into the large group market as opposed to the individual market. The individual market tends to be more expensive, more restrictive. That's where you get the underwriting for pre-existing conditions. The large group market, because the market is so large, those issues just simply get absorbed into the size of the market. The rule for association health plans, I thought, was a brilliant move. We'd tried to get legislation like that through the House for several terms, had successfully passed it a couple of times in the House of Representatives. The Senate had never taken it up, and I'm talking about years ago. So the administration did it through the Department of Labor. They did it through rulemaking. Now, there was a judge in either Boston or New York that decided that, hey, that's more than the department can do on the basis of rulemaking, so they've put a temporary injunction on that. But I had a number of people, the Lubbock Chamber of Commerce said, man, if we could have those association health plans, we would we would use that for our Chamber of Commerce members and be able to get them better insurance at a lower cost, and again, with the ERISA protections that aren't available in the individual market. The Tennessee Farm Bureau was another group that came in and talked to me. If we could just have those association plans, we could do so much more. There's another tangent of that type of policy that says health reimbursement arrangements. Now, health reimbursement arrangements have never been enacted in statute, started in the Bush administration under an agency rule, under an executive order. And look, in the previous administration, I hated executive orders, probably spoke against them. You may have some quotes from me about executive orders. Do I see an upside today? Maybe so. But nevertheless, the health reimbursement arrangement that started in the Bush administration, severely curtailed under the Affordable Care Act. But what is a health reimbursement arrangement? A small business owner who says, look, I just no way in the world that I can provide insurance coverage for you, but I would like to help you with your insurance. So a health reimbursement arrangement allows a tax-free subsidy that an individual can be given by their employer and then walked into one of the exchanges, for example, or some other insurance arrangement. Look, this is what members of Congress gave themselves under the Affordable Care Act. No one else in the country can do this unless you're elected to Congress. Now, to be clear, I did not do that, but when the Affordable Care Act came down, you may remember some of this controversy. Leader Reid and Speaker Boehner and President Obama were all concerned that, oh my gosh, written into law that members of Congress have to take this new insurance that we've cooked up, and they may leave in droves if we do this. So we'll give them a carve-out, and that carve-out for members of Congress was, as long as you're in the D.C. exchange, the federal government will then put a significant number of dollars that don't appear on your W-2, don't appear as taxable income, and we will provide that additional help for you to buy your insurance policy in the DC exchange. Two problems with that. Number one, it was the DC exchange, and no way in the world did I want to be getting my health care in Washington, DC. The other problem was I didn't think any of my constituents would understand that. I was worried that there was going to be a groundswell of opinion against the institution because it had carved itself out. I thought that someone would challenge it in the courts and it would be found to be an illegal subsidization of a finite group of people at the expense of everyone else. But I was wrong about those things. No one batted an eye. I exempted myself from that as an individual and just said, you know what, I'll go to and went through the healthcare.gov experience. Back to remember in October of 2013, healthcare.gov went live. The first night that it was available, I went on, tried to enroll. Most miserable experience I've ever had in my life. Finally, about the middle of January, the check cleared, and I was able, like anybody else, I buy on price. I bought a bronze plan in the individual market. That bronze plan was the most expensive insurance that I've ever purchased. It was about $700 a month because I'm so old, and I'd had a health savings account for years. I believe in health savings accounts. The fact that you have a high deductible, but you're able to put some money away pre-tax to cover those medical expenses, that's a very powerful concept and one that I embrace. But I'd never seen a deductible as high as the one I had on this plan that I bought in the bronze plan in the individual market off of healthcare.gov's website. It took me some time to find a plan that was actually HSA compatible. I eventually did, and was able then, I couldn't contribute near the amount to the HSA, the deductible and the amount you're available to contribute. There's a serious mismatch on that. $3,400 is the allowable amount you can place as an individual. $6,800 was my deductible, so you see there's about a 2-to-1 disadvantage there. But members of Congress, as a general rule, don't have to concern themselves with that because they get this subsidy. They can walk into a health insurance plan. Why wouldn't we give that same flexibility to everyone else? There are a couple of other things that have happened. The transparency rule that the administration has put forward, the Medicare rule, some parts I wasn't as thrilled with as others, but I will say that the administration is making an effort to reduce burden on physicians, and the whole concept of let's let doctors be doctors is one that I wholeheartedly embrace. And probably the last one was the kidney care rule. And you think, what in the world? The president going and talking about kidney care? What is this going to be like? So I went down to the unveiling of that executive order down at the Ronald Reagan building. The place was packed. I've never seen so many people, standing room only. The president talked about how end-stage renal disease, the program started in 1972. This is a good program, but maybe research and development in this program has not proceeded at the same pace where innovation has in other parts of healthcare, and he wanted to be sure we put attention on innovation in this space. The people that came up to me after that executive order, literally telling me their stories of what it was like with their dialysis experience or their transplant experience. And I'll tell you where it's really hit home for me. For probably 10 years, I have worked on a law that would allow coverage of immunosuppressive drugs for longer than 3 years. The reality of the situation is right now, end-stage renal disease, that's a bad diagnosis. We got a special place in Medicare for you, so you'll be covered. Person gets that coverage, dialysis covered, meds covered, transplant covered. If you're fortunate enough to get a match and be able to receive a transplant. But after 3 years, if everything worked well, you no longer have end-stage renal disease. You're back to fully functioning, and you're dropped from the end-stage renal disease program. Well, the consequence of that is, you want to talk about a pre-existing condition, talk to someone with a kidney transplant. But the other consequence is coverage for immunosuppressive drugs ceases at that point. And there are indeed stories of people who have gone without, people who have put their grafts, their renal transplant at risk by stopping their immunosuppressives. So this is legislation I've worked on for 10 years that would allow for continuation of immunosuppressives longer than 10 years. Seems like common sense, but some of these things, when you involve 3-letter acronyms, CBO, CMS, name the federal 3-letter acronym you don't like. When you involve the bureaucracies, sometimes things don't work in a common sense, straightforward fashion. And this is one of those areas. I've gone on longer than you intended.
That was great.
The filibuster, you put the line up there. I can talk for an hour if you don't stop me, so
I don't have a
you do
problem
have
with
to be careful.
I do want to give the audience a
Sure.
chance to ask some questions. I will just say, while people are thinking about questions, 435 members of the House, 100 members of the Senate, a handful of delegates. I've had a chance to meet and work with some of them. there are very few people who can bring as much enthusiasm to end-stage renal disease, HSAs, and then take us through both the subtleties of the Rules Committee versus the E&C Committee on a previous bit of legislation. So I appreciate the inner geek in you, Congressman. Appreciate it.
Well, your humble inner geek from North Texas is going to be the most senior member on the Republican side on the Energy and Commerce Committee next year, and I'm going to aggressively compete. I believe we'll be back in the majority next term, and I'm going to aggressively compete for the chairmanship of that committee. Texas has had two chairs in the last 100 years, Sam Rayburn and Joe Barton. Both arguably have done good things for the state. I try not to brag on Texas because being from Texas can be a problem when you involve other states, but nevertheless, I would argue that a Texas chairman for Energy and Commerce, we do a lot of energy here. I don't know if you've noticed, but energy is a big deal for our state, and it would be a big deal to be chairman of that committee. The other thing that I didn't mention, and I apologize about this, but overshadowing everything that we're talking about is this damn coronavirus. And I will tell you, having been in Congress through SARS, through bird flu 1, swine flu, bird flu 2, Zika, and Ebola, I'm as concerned about this one, more concerned about this one than I have been about any of those other episodes of public health crises that we've faced. The numbers that I'm hearing, and I'm sure they're not up to date, but it went from 7,000 cases last Thursday to over 20,000 cases by Tuesday. That's a tripling in 5 days. The lethality rate is not as great as with SARS, but the infectivity seems to be easier, more facile, and the individual-to-individual transmission of the virus is one that all of us should be very concerned about. And the other thing is the possibility, I don't know whether it's been absolutely proven yet, but the possibility that someone can be infective before they're symptomatic. And that is that really raises some serious concerns. So just to say, I think the Secretary Azar made the right decision with some of the things they put in place. I was glad to see it last Friday afternoon. I had been arguing that maybe we need to be a little bit more aggressive, at least until we see what's going on. And sure, provide the help to the Chinese, all the help that they need. I don't know if they've allowed people from our CDC and our Department of Health and Human Services to assist them. If they haven't, I hope they do, because we've got a great deal of experience and expertise in this part of the world. The other thing is there are some drugs in the pipeline, some antivirals that were not available just a few years ago that are showing some promise. I think the patient up in Washington State, if I understand what I've read in the open press, is correct that some of these antivirals may have affected the course of the disease. If so, that's good news for us, and that may be the silver lining to this cloud. But nevertheless, the coronavirus has the ability to, you saw what it did to the markets last week. It has the ability to really change the entire landscape of everything that we're talking about, not just in healthcare, but the economy and many other facets of life.
Yeah, it's a little scary when you start reading about that, right? Questions from you all for the Congressman? We got one here and then one up front. Rita, do you have a microphone handy? So, sir, why don't you tell us your name and your organization, and we'll try to get as many questions as we can.
I'm CFO of a 25-bed critical access in Hamilton, Texas, about an hour west of Waco. And my concern is the MFAR issue that has been pronounced by CMS, and it has the high probability of destroying all of our rural hospitals, because even though we made $1.8 million last year on pure operations, we lost 7.6. Supplemental funding was $8.5 million, and property taxes are only $700,000. We cannot go very far in funding IGT through our property taxes alone, and this has a huge devastating effect if it goes into law.
So he's referring to the Medicaid Fiscal Accountability Rule that the Center for Medicaid and Medicare and Medicaid Services, I think, put out in November. Didn't really get much attention until the past week or so because it's dense bureaucratic language and difficult to understand. But one of the effects will be, as just outlined, because of the pause that it would put on federal funding for what are called intergovernmental transfers between the state and federal governments and local governments with healthcare reimbursement. It poses some serious cash flow risks for not just small institutions, large institutions, academic institutions. So it is something that I am looking at, working on. It's again, the rule was published last November, I believe. I've got the very dense 90-page comments that the Texas Hospital Association has provided, and in fact, I'm going to go get to meet with them after this meeting is over. I will just say nothing has been finalized yet. What's unclear to me is what is the problem that we were trying to fix. Perhaps if we can go back to that, maybe there can be a way to address that problem. The agency says we need more transparency in how these transfers are carried out. Okay, there's a way to get more transparency without killing every institution that's providing care for, Texas does have a significant number of people who are uninsured. As a consequence, the 1115 waiver, that is one of the things that Texas has been operating under since, I believe it is September of 2015, is a way to allow not-for-profit institutions and not-for-profit hospitals and clinics to participate in some federal reimbursement. The 1115 waiver was due to expire in December of 2017. It's one of the things I worked on significantly during calendar year 2017, and at the end of the year, kind of at the 11th hour, we were able to convince the Department of Health and Human Services and Center for Medicare and Medicaid Services that the 1115 waiver was a good thing. There were some changes that were put in, and changes along these lines of increased transparency and accountability. So I'm not sure how we got from there to where we are on the fiscal accountability rule. Had a lengthy conversation with Administrator Seema Verma yesterday. We'll have some additional conversations when I get back to Washington later this week with everything else that's going on. But this is something that's important, and it needs to be at the top of the queue. So thank you for bringing it up. I mean, we're going to hear a lot more about this over subsequent days, and I'll hear a lot more about it in the next hour.
Other questions here in the audience? Over there? Great.
Dr. Burgess.
Yes.
Thank you for what you're doing. I know that all we ever hear on the news is the Republicans and the Democrats. And even here, we have two separate rooms for our Republican and our Democratic congressmen to tell us what their thoughts are on healthcare policy. Could you very briefly just tell us what lies in the domain of bipartisan agreement on healthcare at this point?
Sure, I'll be glad to. And some of the things that again didn't rise to the level of coverage in a newspaper in the last Congress when I was chairman of the Subcommittee on Health and Energy and Commerce. The first standalone authorization for sickle cell research that I've seen since I've been there did pass. This was a bill brought forward by Representative Danny Davis from Illinois. He's a Democrat, but one that I championed in our committee and on the floor of the House. We got it passed early in 2017. Again, with all the other noise that was going on, we did get that through the House. Finally got through the Senate in October of 2018, signed into law in December. And again, the first law authorization for sickle cell research, the last one was in 2004, but it was kind of added on to a tax bill. So this was the first standalone legislation that had passed, and indeed it was bipartisan. Many of you know in this room, Texas received a lot of attention when there was an article published in the Green Journal that suggested that Texas was an outlier in maternal mortality, that this was a significant problem that was unique to this state. Now, it turns out there probably was some inaccurate data in that article, and they since published a follow-up article, but I promise you it's not a politically palatable argument to me to say, well, it's not that bad. Any maternal death is too many, and we do need to focus on that. In the last Congress, again, when I was chairman of the Subcommittee on Health, on Energy and Commerce, we passed the first standalone bill dealing with the reporting of deaths in the immediate and within the first year of delivery. That had not happened before. The reporting systems are different between the different states, and okay, that's as it should be, but we wanted to provide guidance and funding for states that wanted to set up maternal mortality review committees and to perhaps look towards standardization of how this data is reported. A follow-up from that, as that bill now has become law and again signed in December of last year, December of 2018, the follow-on from that has been, there was a bill marked up in our subcommittee that passed out of subcommittee, furthering that concept. When the bill first was introduced, I thought it went a little bit too far. I'm not a fan of mandates, but I'm a fan of state options. So we were able to get the language of the bill changed so that there would be a state option for a lengthening of the time that Medicaid would cover an individual after delivery. And this would not be something required of any state, but any state would have it available. Texas, as you know, came very close to doing something like that in the last legislative session. Don't know how they'll react if this one gets across the finish line and gets signed into law, but my expectation it would do nothing but help. But again, it was an example of bipartisanship. We had the hearing on that, and the witnesses that were assembled were sort of designed to make this a partisan argument. But why would you have a partisan argument about something like reducing maternal mortality? I was allowed to call one of the four witnesses that day, and Parkland Hospital has already been referenced. I called one of my counterparts from Parkland, the head of the residency program there, who talked about how Parkland delivers, of course, obstetric care to a population that is arguably at risk, low income, uninsured, underinsured, a significant minority makeup to their demographic, and yet they have some of the lowest maternal mortality statistics in the country. And this, I thought, was important for people in the committee to hear. This can be done correctly. There's no reason in the world that we don't focus our good intentions on how do we bring other places up to the good level of care that we're able to provide in Dallas County, Texas.
Congressman, we're out of time. I want to just say on behalf of, I think, the community that state reform tries to foster and build and support and in this instance represent, that regardless of one's politics, I really commend you for your thoughtfulness and your unwavering ability to answer questions that are both political and deeply policy-minded. There are very few people, as I mentioned, who can run the full spectrum of these topics in healthcare and do it in front of a group of pretty smart folks. So let's give the Congressman a round of applause. Michael Burgess.
Thank you.